Hello, everyone. Today, I have the pleasure of having Dr. Varun Lakmani. Varun is one of my close friends from medical college. I have had the pleasure of knowing Varun for almost 8 years right now. He is a research fellow at the Mayo Clinic Rochester division in the Department of Gastroenterology, and he's pursuing a research fellowship in the Department of Pancreatology under Dr. Shaunak Majumdar, someone who I used to work with. That being said, Varun was able to secure a residency in internal medicine, specifically primary care track, at the University of Maryland, Midtown campus. He chose to pursue his residency in the primary care track specifically under internal medicine. So today, the purpose of this interview is twofold. First of all, I wanted to speak with him about step 3 and his experience securing a 250 plus on step 3, and also why Varun chose primary care over the other internal medicine tracks, and discuss about it. All right, Varun, go ahead. Would you like to introduce yourself?
Hi, Dr. Chatterjee. It's a pleasure to be here. So I think that was a very generous introduction for me. I just want to say I'm happy to be here and answer any questions which people might face regarding their step 3, and give a bit of a snippet as to how primary care is how people could consider primary care in their training after doing their residency. So I'm happy to help out in those aspects.
So let's talk about step 3. One of the questions which people usually ask is what are the eligibility requirements to take step 3? Like, when are you eligible to take step 3?
So obviously the eligibility requirements for US grads versus international medical graduates are different. As an international medical graduate myself, I would like to say for us, the requirement would be to be ECFMG certified. That means currently that you have to satisfy 1 out of 6 pathway requirements given by the ECFMG, and simultaneously have your final medical diploma verified by ECFMG. I just want to add a snippet to this that you cannot apply for step 3 until and unless they actually issue your ECFMG certificate. Even if you certify those requirements and verified your diploma, until and unless you get an email from ECFMG stating that the certificate has been issued, you cannot apply for the step 3 exam.
That's very good to know, because a lot of time some applicants are going to apply without an ECFMG certificate, not having step 3. So you need both to take all the steps, clear all the steps, get done with the English exam, which I guess is like TOEFL in our case, or IELTS.
Occupational English exam, the OET exam.
Perfect. Oh yeah, they keep on changing this. So step 2 CS is gone. So you need step 1, step 2 CK, OET exam, and then you need to have the ECFMG certificate. All of this to take step 3, and step 3 results also take almost about 3 weeks, 4 weeks to come.
Yep, that's about the average turnaround time for that.
So you should get your ECFMG certificate almost a month back, if not more than that, to take step 3. So it's like a long process. So maybe what would be an ideal time? Like if the application season, let's say, opens around September 15th. So when should you be done? You should have ECFMG certificate in your hands to go for the step 3 application.
Ideally, I would say that, try to satisfy the pathway requirements as soon as the pathway applications open up. For this year, the pathway applications have opened up, and I'd encourage all international medical graduates to submit the pathway application and, upload all the necessary documents for either of the 6 pathways. And the ERAS this time is opening on the 2nd of September, and the application deadline is at 29th of September. So ideally, you should give your step 3 exam before you turn your application in, or that would be an ideal situation. However, due to the stringent timeline, it might happen that some applicants might elect to take the exam after turning in their applications. So you can also inform programs after you've gotten your step 3 results, stating that you have your step 3 score in.
Perfect. So the next question is, why should we take step 3? Like, why should I care? Most of the people would, most of the residents would take step 3, after joining residency. Why should I care as an international medical graduate to take step 3 even before applying for residency?
That's a good question. I would say that for international graduates, since USMLE step 1 is becoming pass and fail, I feel that in order to stand out as an applicant, a good step 3 score above the average would look good on a person's ERAS application, first of all. Secondly, I feel that having step 3 done before starting residency just makes you an overall less liable applicant. This applies particularly to those people who are older graduates and have lower USMLE Step 1 and Step 2 CK scores. I feel that the Step 3 score is like a final chance for you to redeem yourself, to score well on a standardized examination. So I think Step 3 would ideally help you to get even more interviews and potentially even help you get a higher rank than an applicant who doesn't have Step 3 potential.
Yes, I was told the same. Like step 3 doesn't matter. You can take it. You might not take it. Like it's up to you. I did not personally take it because I did not have the time. But if I had the time, I would have taken it. That being said, I think in your case or in people in other situations, when you have seen like people who took step 3 got a few more interviews, and then while it comes to rank candidates, like if I have a candidate with USMLE Step 1 pass fail, USMLE Step 2 CK, okay score, a good score, no step 2 CS, so that's gone. And then a candidate with all of those things and a step 3 when he or she is done. So I, being the program director, would probably prefer the step 3 candidate. Like if everything else is considered equal, this is like very difficult to judge, but if you can take it, might as well go ahead and take it. It requires you to be in the United States. That's kind of difficult. Like not a lot of applicants would be able to travel to the United States to take step 3, but if you have the opportunity to do it, might as well just go ahead and do it. Do you agree with this statement, Varun?
Absolutely, I agree with everything you said. I think it makes sense.
Perfect. What are the few must-use resources for step 3, you would say?
So for step 3, again, the first resource which I think everyone should be thorough with is the UWorld question bank. I feel that solving the UWorld question bank at least once would help tremendously with your step 3 preparation. Along with the UWorld question bank, I would highly advise all applicants to use the Divine Intervention podcast. Divine is basically a radiology resident at Hopkins who makes videos, podcasts and videos to help people with the USMLE preparation. I think these podcasts are like a gold mine for knowledge, and if you can actually listen to these podcasts at regular intervals, then it can, help you in your learning. So I think these are the two main resources which I used personally for my step 3 preparation. After getting done with these two resources, I went on to revise my UWorld Step 2 CK notes. Along with the UWorld Step 2 CK notes, I had to brush up on a bit of Step 1, pharmacology and microbiology. I think they are heavily tested on day 1 of Step 3. And I feel that going through the first aid book for these topics carries immense value for applicants.
So let's break it down. So you said UWorld for step 3. That's like the main question bank. I think like how many questions do they have nowadays? Like 1600, 1800 maybe?
Yep, that's the ballpark.
So yeah, so how many times would you recommend someone doing step USMLE UWorld for step
I think
3?
that would ideally depend on how far you are from your step 2 CK. That's one thing. And secondly, it would depend on what your timeline looks like in a way. I mean, if you have time, I would highly suggest people to solve UWorld twice. But if you're in a crunch for time, you can just solve it once and solve the incorrects and the questions you flagged at a later stage, just so you can ensure that you're actually thorough with all the material.
Perfect. So maybe UWorld twice, or maybe just once and then the incorrect once. Then you said the Divine Intervention podcast. I remember you suggesting that I did do the same. I didn't get a 250. I think I got like a 240 something, but I think Divine podcast really helped me because I was getting like 230s on the UWSA 1 maybe. And then I also took some time to like hear the Divine podcast before taking the exam. So I vaguely remember like he had divided it based on like USMLE Step 1, Step 2, Step 3. Did he do this, like did he have like an Excel sheet or something where he kind of like lines out what you need to listen based and what will be high yield for this particular exam?
Sure, yeah. So that's exactly what he did. You can go to his website, divineinterventionpodcast.com. As a disclaimer, I have no affiliation with him whatsoever. You can just go on this website and there's like an Excel spreadsheet where he divides all his podcasts on the basis of Step 1, Step 2 CK, and Step 3. You can listen to the podcasts under Step 3 as well as Step 2 CK, and I think that that will actually help you navigate better through the Step 3 exam in a way.
Perfect. And then so that's UWorld, that's Divine's podcast. Next, you said about revising step 2 CK notes and maybe even first aid for step 1. So you already mentioned about biostats, pharmacology, maybe microbiology. What else should like examinees revise before going for step 3? I know day 1 can be a little like there can be like a lot of basic science questions. Like I remember like getting a lot of basic science questions, which I did not remember on the top of my head. But apart from those subjects, like anything else which people should be looking at, like a last minute thing before going for day 1?
I mean, that's a great question. For day 1, I feel that biostats is something which is very heavily tested. So I would suggest to even use the Amboss Q Bank and get through with the drug ads and the drug ads questions and the questions with the biostats question where they ask about statistical analysis, the type of analysis and everything. So getting thorough with biostats is something which I think every applicant appearing for the exam should be comfortable with. And secondly, for basic sciences, I mean, I feel that the sky is the limit. You might just get questions from embryology on step 1 and you might just not be prepared for it. So I would just suggest you to focus mainly on the microbiology, the biostats and the pharmacology section of first aid and supplement it with divine intervention. And I think you should be good to go.
The next portion of step 3 is CCS cases. Now, this causes a lot of confusion and tension among applicants who is going to take this examination. I think I undervalued the importance of doing CCS cases. And that's why maybe I scored like 10 points less than what I could have scored, 10 or 20 points less than what I could have scored. That being said, you did pretty well on CCS cases and you were more comfortable than me when I took my step 3. So what was like your go-to approach for doing CCS cases and what would you suggest examiners to do?
For CCS cases, I think the main software which I use for ccscases.com, I found it to be a resource which was closer to the final exam, which I faced. It has like about 105 cases. The main value it carries is that it gives you feedback, real-time feedback as you solve each case. I think that's really invaluable because oftentimes we know, what to treat with and, where the patient should be, but sometimes the sequencing is wrong. Sometimes you start the treatment too late. Sometimes the patient deteriorates. So in order to get the sequencing right, the timing right, I think software which gives you real-time feedback is essential in order to get through with CCS cases. UWorld also has its own CCS cases software. There are about 30 to 40 cases. I feel that they're a useful practice after you get through ccscases.com if you have time. Finally, I cannot stress this enough, use the NBME software on the website, which has like 5 cases with, again, feedback. Read their explanations and see how they're trying to explain those cases and what they want in the exam, so that it gives you an insight as to how they frame their cases and how the order should be put in.
Yeah, perfect. So ccscases.com, UWorld CCS cases, and then obviously this is obvious, like if you are short on time and then you want to do something, at least do the NBME software so that you are kind of oriented to how the examination software looks. Absolutely. Because otherwise you're going to end up failing, and CCS is not something which people take seriously. I think even if you are unable to go through all of ccscases.com, I could not do everything. I did like maybe 50%, but like Varun said, and I also suggest the same thing. If you have the time, go through all 105 or 110 cases, get it done, maybe even supplement that with the UWorld cases. In my personal experience, the CCS cases were slightly more difficult than the UWorld cases, maybe even slightly harder than the cases which you're going to face in the exam, but it really prepares you well for the exam. And this is something which a lot of people will kind of like slack off or like kind of push it between like the day 1 and day 2. Hey, I'm going to take 5 days to do the CCS cases. I kind of advise against this approach. I would rather have everything done and well prepared before day 1, and then kind of take a few days between day 1 and day 2 to revise the CCS cases. That kind of brings up to our last questions regarding step 3 is, how should you schedule step 3, like between day 1 and day 2? Like how much time would you take? Would you take it like day 1 as in the first day, and the next day you take step 3 day 2, or how would you like to kind of schedule it, and what do you think works best?
Yeah, I think that's an important question as well, because I've seen many applicants doing it, one day after the other, people taking more than a week between day 1 and day 2. What worked for me is that I took like a 3 to 4 day gap between day one and day two, I actually felt really burnt out after day one, and I just felt like I needed to sleep for a couple of days. During those 2 days, I did not study, I did not do anything, and it just refreshed my mind. I feel that you need a fresh mind for these USMLE exams, as people would know. So a 3 to 4 day window would ideally be the best scenario. For between day one and day two, I feel that a larger gap might just make you forget things in between, and that can potentially harm you. So definitely keep some break, but not too long.
Okay, that sounds great. I think this is applicable more towards IM residents or like prelim IM residents where they don't have a lot of time. So you are kind of stuck between taking like the first day and the second day like back to back. If you're able to sneak in a couple of days, even like one day, I would highly suggest it, because after an 8 hour test, you're kind of destroyed. You just want to come home and sleep and not like go through anything. That being said, like just having an extra buffer day just to relax and kind of there is like not too much point in like revising, but just having that extra buffer to relax and take the exam on the day after the first day, that makes more sense. Like if you are someone who is not short on time and you have all the time in the world, make sure you take like a good 3-4 days, maybe even 7 days. I took mine like a week apart, and that worked great for me. I was well rested, but oftentimes it can be challenging to find days, and like you will have to like travel to other parts of the US to like take this step 3, because in my time it was like peak of COVID, so I only found like maybe a few centers doing it like a week apart. So it's kind of like it's going to depend on your case, and it varies case by case basis. Okay, perfect. So that kind of brings up the next section, which is like one of Varun's favorite section. Like he chose to pursue a career in internal medicine, not only internal medicine, kind of specifically looking at primary care track. That's not something which a lot of physicians usually prefer, like primary care. So let me start off by saying this, like what is primary care, Varun, and why did you choose to go into primary care?
That's a fair question to start with. Primary care is predominantly, or rather 100% outpatient medicine, where you see patients in a continuity clinic, manage the chronic conditions, and, in simple terms, you're their family doctor in a way. So primary care for me was an adequate choice because I had like 3 months of rotations in core primary care IM. I had a decent exposure to outpatient medicine during these times, along with addiction medicine and other aspects of primary care, which people don't usually have an idea about. As soon as I, thought about applying, I got advice from various mentors and seniors that, apply to primary care tracks as a backup, and there's no scope for any future fellowships, and it might just set you back in a way. If you're not interested, then just back off and don't do it. But when I did my rotations, I just found out that I just loved talking to the people in the outpatient setting, working through their problems and counseling them really well. So in my niche, I have found that primary care was something which I would thoroughly enjoy doing, and so I just went for it during the application cycle.
So perfect, like outpatient medicine. So today I had my own primary care clinic, so I can kind of like expand on what Varun said. It's an outpatient setting. People, less sick people come in for health maintenance stuff, usually our hospital discharge follow-ups. And then you get to see patients in this outpatient setting. It's like a much more relaxed situation than the inpatient setting. Your day usually starts around like 8, kind of ends around 5. It's like 5 days a week. So now, the next burning question is fellowship aspirations, like someone who wants to go into cardiology, GI, HEMONC, like or other competitive fellowships. Like oftentimes they would not prefer primary care track. Do you think there is an aspect of like someone choosing primary care and then kind of going into this like highly competitive fellowships?
I understand the apprehensions which people have regarding fellowships after primary care. Not being fully acquainted with the fellowship data, what I do know is that the top 3 fellowships, particularly cardiology, gastroenterology, and pulmonary critical care, these are potentially specialties which are inpatient heavy. And if you do your residency in a primary care track, spending a lot of time in the outpatient setting, then it might carry a negative impact on your applications simply because faculty and mentors in the inpatient side might not see you that much, and you might not be able to create an impression on them. At the same time, there are outpatient-oriented fellowships, including endocrinology, rheumatology, and even some hem-onc, office-based hem-onc fellowships, where they would actually be interested in outpatient-based primary care tracks. So I would just ask applicants to, maybe do some soul searching and self-reflection and think about what they want from their futures. I know it's really difficult from an applicant's perspective while applying to residency to think about all this, but having a little knowing a little more about yourself never hurts you in the long run. Applicants should not have the perception that programs look upon primary care tracks or people wanting to do primary care as, somewhat, somewhat less competitive. I feel that there's a huge incentive coming from grants from the federal government and state governments to increase primary care physicians in this country. And if you're interested in primary care, then you should by all means mention it in your personal statement and have a sound and thorough reasoning as to how and why you want to pursue it.
So one question which can be asked is why primary care? Like why primary care is good for me? Like as an IMG, should I be considering primary care? Like a lot of time, primary care spots go unfilled. Not a lot of people apply. Like as an IMG, does this give me an additional benefit when it comes when purely comes to match? What do you think, Varun?
There are I feel that there are two schools of thoughts here about how programs look at people wanting to pursue primary care. One school of thought would be that if you are a local in that area and you have strong ties to that area, then you wanting to pursue primary care and potentially, serving that community in the long run would make you favorable as an applicant and as a candidate. Secondly, I think that the core aspects of primary care was something which I think all IMGs face in their country, which is like the social determinants of health, healthcare disparities, and marginalized populations, underserved healthcare, inaccessible healthcare. So we are no strangers to the core problems and the issues in the outpatient setting. So potentially we can use that as an advantage because we all countries have those same core issues in the medical system, and us having an insight into how our medical system works and how the US medical system works kind of makes us someone who is better informed and an applicant who has thought things through.
Perfect. Yeah, it's a very difficult choice to choose primary care, and you will have to have a lot of insight. It's not something which I thought thoroughly before applying. I would have to be honest. Categorical IM is what I wanted to go to, and I did not really think much about the primary care track. As in, I did not know. So I think this video was kind of meant to help a lot of people to know what a primary care track is and whether to apply or not, and what the implications are going to be. That being said, how is the future different from categorical IEM? If you do a primary care track, thinking long term, what are the chances of you securing a good job as an IMG? I would say, as an American medical grad who is not on a visa, I think job is looking for jobs is kind of different, and everything is kind of open for you. But someone who is on a visa, getting a job on from a primary care track based IM program versus a categorical track versus someone who did their fellowship, I think those are very different things. So would you be able to elaborate on that, Varun?
Here's a fun fact, the Conrad 30 program, which was started, was mainly to fill primary care shortage in the United States. So I do not think that there will be any issue in you either A, securing a job, or B, wanting to stay in the United States for a longer period of time and serving underserved areas. So I think from the perspective of securing a job, there are decent community programs, even university programs, which who are actually looking for primary care physicians. There's an acute shortage, as everyone knows, of primary care physicians in this country, and so I would say that there are no potential employment setbacks you will face in the future. At the same time, you should actually absolutely be sure that you want to be a primary care physician. You can also do primary care even after doing categorical medicine. But what I found after giving interviews in the primary care tracks is that even with categorical physicians trying to practice primary care, I think the primary care track is better suited to your needs, and it prepares you better than a categorical internal medicine resident for the outpatient style that you won't practice in the future. So it's something which I think, if you're well informed, would be actually a good choice for you in the long run.
Yeah, and then the lifestyle, of course. So yeah, that kind of like perfectly sums up the video. And I would say thank you, Varun, for taking out time out of your busy life. I would say enjoy the last few days. July is coming, so be ready. So best of luck, Varun, for your residency. It's going to be tough. Intern year is always tough. Once again, congratulations for securing this residency. Congratulations for this great score on USMLE Step 3, and best of luck for your future.
Glad to be done with all. Thank you, Dr. Shah.
Yeah, all right. See you, Varun. Take care now. Bye.
See you. Bye.